All right, well, welcome everybody. We will call our May 29 Board of Health meeting to order. Let's start off with roll call. Oh, I don't have a full list. Do you?
I don't.
No.
Go around the room, or do you?
Yeah, let's go around the room. Commissioner Kearns?
Josh Kearns, Spokane County Commissioner.
Monica Blakowski, May.
Dr. Velasquez, Health Officer.
Alicia Thompson, Administrative Officer.
Commissioner Cooney?
Commissioner Mary Cuney, Spokane County.
Mike Cathcart, Vice Chair and Acting Chair today.
Patricia Keenholtz,
Okay.
Michelle Fossum, Legal Counsel.
And Pittsnogle, Recording Secretary.
All right, thanks, everybody. Do we have anybody signed up for citizen input? Oh, can somebody let Amber in the meeting there?
We do not have anybody signed up.
All right. Can you let Commissioner Waldron? Commissioner Waldriff, can you hear us?
Yes, thank you.
All right, very good. Okay, nobody has signed up for citizen input, so we will move to board reports. Commissioner Waldriff, do you have a chair report?
The only thing I was going to mention is there is the National Boards of Health NALBO conference that's coming up in, I think, October. And Dr. Thompson and I were talking about this, and I think there's money in the budget for several board members if they want to attend. So if you're interested, you know, talk to me or Dr. Thompson, and I think it's October, early October this year in Savannah, Georgia. So just putting that on people's radar.
Okay.
I don't think I have anything else to report.
All right, well, thank you for that. Is there a executive committee report?
I can chime in. I was
Yeah.
there. Essentially, I mean, we met to set the agenda and just sort of go over the items we're going to be discussing today.
Okay, how about budget and finance? Do you have a report?
Budget and finance, we met, went through the vouchers and financials, and everything looked good. And I think we were talking about treatment services on the budget there, so I think we'll be discussing that further today.
Okay, very good. And the policy committee did meet and talked about some of the items that are related to executive session. And so with that, we will move to our consent agenda. Can I get a motion to adopt the consent agenda?
I'll move to approve consent agenda item number 5.
All right, is there a second?
Second.
Okay, motion and a second. Is there any further discussion? Hearing none, all in favor, say aye.
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 Any opposed?
Aye.
Consent agenda is approved. Reports, administrative officer.
Good afternoon. So this is the agenda that I'll be covering. I want to go over the updates that have been done to the website, and then also encourage you to fill out your oath of confidentiality forms that should be in front of you. And then we'll give the treatment services updates, and then we'll talk about the treatment services expansion proposal. So last month, or was it last month or the previous month, we were asked to update the Board of Health website on our overall website, srhd.org. And now what you see when you go to that page on our website is an updated picture of our current board, and you also will see these tabs that say minutes and past meetings. And when you click on the minutes, you'll be able to go in and click on that plus sign, it will drop down, and all of the meeting minutes will be there for you. And I just took a snip, and so it does go into the past years as well. But I just took a snip to show you what it looks like, so that all of those meeting minutes are available to everyone, the public, everyone, okay? Then when you click on the past meetings tab, what you're going to find is the meeting materials. And so it's set up in the same way. You can click on each meeting and find all of the materials that were a part of that meeting. And so we're hoping that will be very helpful to the public and to all of you as board members. Any questions?
I just wanted to check, Commissioner Cuny and Waldrop, can you see the screen here? I just noticed what we're seeing in the room doesn't show a preview. Are you guys able to see the screen that Dr. Thompson is showing?
I was actually just going to weigh in and say I can't see I can see Dr. Thompson, but I can't see the screen. And I think one time when I zoomed in earlier this year, I could see the screen.
Is it just a matter of sharing? Are we able to do that?
So, Anne, do we need to check in with Christian, or? Because I think it is important for them to be able to see the slides.
Folks that are watching the video stream, can they see the slides?
They can see the
Okay.
slides. It's just here in the room they can't,
Okay.
or the ones on Teams.
Got it. Okay, well, we will see if we can figure that out. But in the meantime, do you want to continue on with the treatment services?
Okay, so yes, because the next thing was, again, a reminder to fill out the oath of confidentiality form that requires, okay, we're going to pause while Christian is here to help us.
Sure. Let's take a quick moment.
Okay, we should be able to see
Okay.
it now.
Excellent, yep, we've got a thumbs up from Commissioner Waldrop. Okay, great, okay, I didn't realize it was that easy. Okay, so the next thing is the treatment services update. And so highlights for year-to-date, we've finished 4 months now of the year. And so we are currently at excess revenues of $364,592. Our expenditures are running at 27.7%, and our revenues at 31.3%. You also have this spreadsheet in your documents, in your handbook, that shows, so that you have the exact, what are the expenses, where are the revenues coming from. Are there any questions about the finances of treatment services? Okay, and Misty, you want to come up here? And Misty's just going to go over our monthly numbers for you.
Okay, good afternoon. So you'll notice that this month, the spreadsheet for the numbers looks a little different. So we did this in a way that hopefully is a little bit easier to read, so that under the intakes, it reads and it gives you the breakdown on every month of when we have an individual that comes in for an intake. You can see a little bit easier the number of days from referral from the day that they come in until they're admitted. The number of individuals turned away, individuals that were turned away that came back, transfers or discharges, and so on and so forth. So throughout the first 4 months, then through the 2025 yearly totals, and then in comparison to last year's 2024 totals as well. So we broke this out hoping that it was a little bit easier to read for each of these categories. And we did this with each of the sections with the individual counseling, medical, having the annual physicals assessments. Dispensing, we maintained that we have the unique individual patients that we serve, individuals that are courtesy dosing that we provide services to. The methadone doses dispensed, as well as buprenorphine or naloxone doses. Additionally, the jail, we have it broken out with how many jail doses are dispensed each month, in addition to how many individuals are being provided services at the jail, and how many individual jail assessments or intakes are being done as well. So we just broke it out a little bit different than what it has been done in the last few months previously, so that maybe it's hoping that it's a little easier to understand, a little easier to read at a quick glance.
Is there something different about these assessments, or have we not been doing these all along?
At the jail?
Yeah.
No, it's a matter of, we get requests from individuals incarcerated pretty frequently. We collaborate with individuals and the jail staff, with the medical staff, to determine appropriateness. Because if an individual is going to be incarcerated long-term and moving on to prison, they're not appropriate to enroll. And so we have to do a lot of collaboration to find out if they're appropriate. Oftentimes, if they're already enrolled in services or moving across the state, it doesn't make sense to enroll them into services with us. Oftentimes, they can be receiving medication within the jail, so we have to, that's where the communication with the jail services is really helpful.
Okay. And so, but just January, February, March, not having any numbers there, that's just because there were no assessments those months because of
Correct.
folks were in those situations?
It's just new this month, so I just added
Can you, I'm sorry, Adam, come forward and speak into the mic,
So-
please.
That jail assessments
Introduce
is
yourself.
just, I'm Adam Martin, and I do data, our EHR, all of that for treatment services. That's just new this month. We've done them all along. It's just, you guys were interested in the services for the jail, so I just broke that out and found that specific number for this month as well.
Got it. Okay.
Yeah.
Thank you.
So I can go backwards and fill it out as well.
Okay.
Yeah, so I'll fill it out for backwards, and then you'll see the next month and totaling out altogether.
Okay. Nope, that's helpful. Thank you.
Yeah.
Does anyone else have any questions?
Looking at the counseling sessions and the counselor assessments, the 179, you see that under counseling for the 2025 yearly total. But then looking at the individual counseling sessions, that's 2840. Would it be fair, like how do we come up with the number of people who are receiving counseling? Would that correspond with the counseling, the counselor assessments? So could we assume that each person is getting a counseling assessment? Would those be duplicative? Or you
All the
follow
above.
me? Yeah.
So each individual has an assessment as soon as they come in. And once an individual is enrolled in services, they have the opportunity to receive counseling individual sessions, as much as weekly or as little as monthly. But they also have the opportunity to attend group counseling. So if they choose not to attend an individual session, they may not have the individual counseling. They may attend a group session. So they have the opportunity to kind of pick and choose a little bit what works for them, and working with their counselor for what makes the most sense for their recovery efforts. So that 2840 is indicative, you're correct, of and one person receiving multiple sessions throughout the year.
And so the counseling is optional?
Programmatically, we do require it. So as with SAMHSA's new regulations, they don't necessarily require, it is considered best practice. And we really strive to not make it punitive if they don't attend. However, it is best practice, and we do highly recommend, we do encourage, we work our counseling services. All of our staff work diligently to do our best efforts to engage the individual.
So the 179 would reflect the number of people who accepted doing the
That's,
counseling?
an assessment must be done in order to
Okay.
enter into service.
Okay,
That's an absolute that has to happen.
yeah, okay, I get,
Yeah.
now I follow, thank you.
And so you'll see that the counselor assessment and the medical assessments, while granted there's a one number difference, those are typically matching because those are the same thing. So when an individual comes in for that initial intake, they have to see the medical provider and the counselor. Those are the same, that's the same date typically. Now, that number on there for the total for April is off, and that generally happens in the event if an individual goes in to see medical, but then they start with the counselor and they decide, no, it's too much, I don't want to do this, it's too long, I don't have time, and they walk away. Or they are an inappropriate admission.
So they wouldn't, so the unique patients served doesn't really relate to that number because of that?
In dispensing.
Yeah.
Sorry, I'm going to step in. So the unique OTP patients served are the number of clients that were served with dosing. During the assessment process, as Misty was stating, not everyone completes that assessment process. And so if they received dosing, they completed the assessment and they received dosing, then yes, they are counted in that unique OTP patient served. But as Misty indicated, some people walk out. And so if they were dosed, they would be included. If they walked out, they would not be.
Okay. Other questions? All right, keep going.
Oh,
Oh, please,
I had a question.
go ahead, Commissioner.
I was just noting that we're already at 1,085 unique served, and last year we were at 1,369. I was just wondering if you thought we would meet that same number or it'd be greater. I guess we still have 8 months of the year, right?
We anticipate that, but again, one thing I have been thinking about is redoing that marketing campaign that we did last year and going through that and doing it again. And I think that is something that could help with our numbers to go up.
And then also there are still people that maybe haven't returned if they can't get in the day that they show up for a walk-in, and that's what, we're trying to think about, if we can have more of those opportunities to assess people and get them into the program, more of those walk-in hours, right?
Correct.
Okay, thanks.
Okay, so last month, it was mentioned that we hadn't presented a proposal for the expansion. And so we did develop an expansion proposal so that you had more information. There are draft copies on the back table, and I believe you received a copy prior to this meeting. And so with that, I'm just going to go over this slide and then I'll turn it over to Misty. But we feel that there's significant unmet demand in Spokane County. And part of that is that in the second half of 2024, we had to turn away 193 clients who came to us, they were ready, they wanted to start the program, and we weren't able to serve them because we didn't have the resources to do that. And then in the first quarter, we've already turned away 54 clients, and it's due to our limited capacity and restrictive operating hours. We see as many walk-ins as we can, but with our current staffing, we're not able to see them. And then anecdotally, I've had conversations with people that have seen clients driving up to the door, looking at the hours, trying to see if we were open after our normal hours. And that's a question that Board Member Blakowski-May submitted that Misty's going to address later in the question time. Okay?
So, over the last few months, I know we've talked about a number of things that Treatment Services offers and how we operate. And this just really kind of gives you a high-level overview of the exact services. So we've got our medications of the methadone, buprenorphine maintenance treatment, individual and group counseling for opioid use disorder. Additionally, we do our medical and clinical assessments at intake. We also have mental health counseling and group therapy on site, which is a huge help for individuals that need the services there. We also provide urinalysis testing and breath analysis. We have case management, resource referral. We do on-site EKG and lab work, which is, again, incredibly helpful that we do those things on site versus having to send our individuals out into the community, and it's all done under one roof. And without these changes to be made, we're going to, and changing in the capacity and scheduling, will continue to have to turn away individuals. This is something that we've been seeing and we've been tracking for the last, 10 months? And we've noticed, and we've got the data to support it at this point. And if we're unable to make these changes, our program will have to continue to do this, and we'll have to continue to turn individuals away at the point in time that they're ready.
So I also wanted to talk about the financial stability of treatment services. And so over the course of the past 7 years, Treatment Services has generated $4.4 million in surplus revenue that has been contributed to the general fund. Revenues have consistently been increasing over this time. And yes, we did have a shortfall in 2023, and that was due to multiple different issues, but the main one was that Treatment Services was paying for and covering the costs for 2 separate buildings in that year. And so the revenue that we generated wasn't enough to cover that additional expense. Okay, and Monica did have another question about this that we will cover when we get to the questions.
So with the hope of expansion, our goal is to reach all individuals that seek treatment. At the moment that someone seeks and asks for help, that's when we want to be able to help them at their most vulnerable point, and providing the intake and all services. And by extending the hours, that's when we'll be able to do that with the later availability. This would give us the opportunity to change our hours from what we currently operate to Monday through Friday, 5:15 to 6, with Saturday 7 to 3. This would change and give us an estimated, again, this is a crystal ball opportunity. This does not give us exact, this is an approximation, an increased client capacity of dispensing to approximately 1,150 individuals across an 11.5-hour day. Increasing our opportunity for up to 30 intakes in a week, with a general average weekly census between 12 and 1,300.
And Misty, would you like to go ahead and explain why OTPs have these hours?
Yeah.
I think that would be one of Monica's questions that would be great to address here.
Of course. So starting at 5:15 is not always desirable for a lot of individuals, especially when it comes to recruitment issues as well. However, OTPs typically start at such an early hour because of the fact that once an individual becomes stable in their program, the goal is that they're working, they're employed. And whether they're working to become employed, or they come to us already gainfully employed, or they have a home life that warrants that. The idea is to have the opportunity to have a program that meets the patient where they're at and offers services to them when they need it. And for a lot of individuals, that means the working population needs to have services early morning hours, not at 8 a.m., 9 a.m. only. It means earlier morning, which is why so many programs, not just in Washington State, but nationwide, OTPs are open early morning hours. And staying open later is becoming, slowly but surely, is becoming a more progressive trend with OTPs in order to meet the patient population needs. But the early morning hours has been historically to help those individuals that either are already working, or to help them once they become stable in their recovery to become gainfully employed.
One question, maybe I'm just misreading it, but total of 1150 per day, but then the weekly census is 1200 to 1350? Can you just,
Yes, so that number of individuals that come through, so currently, let me back up. So 1,150 individuals that would come through in a day, some of those individuals would have take-home doses. Not, if we had, say, 1,350 in the entire program census, not all of them would need to come through every single day. Some of them would only come in once every 2 weeks, some would come in every other day, some would come in every 2-3 days. So it would just depend on their take-home carry schedule.
for the take-home, do we have a policy around how far out that take-home is allowed, or?
Oh, yes, absolutely.
And what is that?
So
gonna be?
SAMHSA's guidelines permit up to 28 days. However, internally, our program only permits up to 14 due to safety concerns and adherence, and wanting to ensure that there's active engagement with the patient, and wanting to continue to retain the patient and have that engagement with all of the staff that they encounter, from our clinical assistants, security, counselors, dispensing nurses, front desk staff, all of them. So it's, we typically maintain the 14 days worth of take-homes.
Just so I can kind of wrap my head around, so that this is the estimated if the expansion took place. So what are the numbers today, just so I can see the difference? So you say this would bring us up to 1150 a day. What are we currently a day right now without the expanded hours?
Per day, we're dispensing to probably between like 400 is the most standard, but up to like 5, 6. It just,
Okay.
like she said, it depends on
Okay,
the
so
carry schedule.
this, I mean, easy to say at least double, I mean, is what this would do then.
Absolutely.
Okay,
Yep.
okay. Could I do a follow-up on that with, I mean, when you increase hours, when you increase staffing, all that, on your previous slide with the trend line, I mean, that's going to also make your expenses line go up. I mean, have you drawn those out to just,
Yeah.
I mean, we're
Well,
gonna get to that?
We
We're
have
gonna
a
get to that slide?
Yeah, we
Okay,
have a
I
slide
just-
for that.
Okay, because I'm just saying, if you don't hit these numbers, those
Mhm.
expenses are still there, because you still have the staff there, so,
Mhm.
okay,
Yes.
all right.
Tricia, go ahead.
I saw a company recently that provides services where they go into facilities and provide things like counseling, medication, dosing to people. I'm curious if you're familiar with that, and if you're, since you know a lot more about
So
OTPs than me.
I think I would, before I answered all of that, I'd feel more comfortable knowing a little bit more, because if they're providing methadone, or if it's buprenorphine, or what type of medication. There are a number of programs that go into homes and programs that do provide counseling services. We are actually in the process of recruiting for a community-based position for a counselor to go and do intakes or assessments and work with community providers to help do that engagement, and potentially some counseling as well. But taking medication into the community, that's a different issue when it comes to DEA regulations.
Just one other quick thing to back up on the counseling part. I think it's important to know whether the counseling is for mental health counseling or if it's for just the standard that you require. And I'm not sure that that's in this breakdown here.
Right, so the breakdown in the services that are provided is all specific to substance use disorder counseling. So the
Okay.
mental health counseling currently is, we have one mental health provider.
So maybe add that in the future if you expand that kind of counseling. Okay, thanks.
Well, I'm going to tag on to your question, Board Member Keinholz, because this was something I learned as we were preparing this proposal, is that we actually have, partnerships with some of our community organizations where they actually bring their patients to us to dose them. And so I don't know the specific organizations, but I'm sure Misty could quickly just, so those outside organizations are bringing their individuals to us.
So we have skilled nursing facilities that we partner with that they bring the individuals in, and we do a chain of custody with them so that they can have the medication in the facilities. We also have inpatient treatment facilities that we work with, and they bring the individuals in. They pick up the medications, bring them into the inpatient programs there too. Okay, so in regards to staffing, with the proposed expanded hours, we had looked at what that would require. And essentially, we would look at 2 counselors, a nurse practitioner, 1 medical assistant, an administrative assistant, an RN, a clinical assistant, and 1 security guard, or security officer. And with that, all of those positions, those staffing costs are the $770,397, plus the expense of the indirects comes to a total of $889,423.
And there are some additional expenses, but we anticipate being able to cover those, like the supplies and the medications, with our excess revenues.
Can I ask, generally, for those positions, how, do we know what the ratios are right now for the number of those staff members to how many patients they can handle?
As far as the counselors?
Yeah, the whole, everybody, essentially.
So currently, we have, with approximately 960 patients, we have 14 counselors. So I don't have that off the top, but with the increase in numbers, 2 counselors to begin with to get started would be sufficient. We may need to increase that as numbers would increase, but the increased revenue would support that. As far as nurse practitioners, we currently have 3. We are recruiting for a 4th, so that balances out to approximately 320 patients per ARNP.
Are there any, do we have anything that commits us to a certain level of workload, whether it's through the kind of bargaining or anything else that we have to be cognizant of?
So not when it comes to workload, but we do have some restrictions on asking our union represented employees to change schedules. And so that's why we would need to hire these outside positions, because they would be specific to that schedule for the expanded services. And, you know, this won't prohibit somebody that's currently employed with us for applying for that positions, but we do have to create the positions because they are outside of our collective bargaining agreement. And so, yeah.
Okay.
So I shared this question with you earlier, and you maybe were going to answer it, but I was curious about what these position distributions were based on, if there's like standard staffing models for an OTP program of a certain size, if that's what this is following, that would be great to know. Or if it's, you're taking the current ratios that you have described already and, you know, expanded it out and just said, okay, we're gonna see this many more patients, so this was what our current ratios would expect. So does that make sense? Like,
Yes. So it's not necessarily specific to a model per se. However, looking at what our program structure is at now and what the need would be based on the potential increased patient census, that's where we would be looking at how to cover that patient census without any disruption to the current staffing structure or patient care.
Just with regards to the Medicaid and Medicare, do they reimburse 100%, or is it a portion of? And I'm just curious, does it keep up with our COLAs and pay increases and all that? Is there going to be a point where we really start to exceed in a couple of years?
Exceed our expenses?
Expenses will be greater than.
Every 2 years, at least every 2 years, in the past, the Medicaid and Medicare, they look at their reimbursement rates. And that's one of the pieces of work that Misty does in her role as the chair of WASATAD, is work with them to help them realize that they do need to increase the reimbursement rate. And that just happened January 1, 2023. Is that correct, or was it 2024?
2024. And there's actually been a work group that we meet twice a month currently, and there's discussion currently about the reimbursement rates because all OTPs are a fee-for-service, and there's discussion about potentially unbundling. What does that look like? What makes sense? But none of that will happen for 25. It's a discussion for possibly 26, but everything is kind of up in the air at this particular point in time. As far as the reimbursement rates, yes, they are at 100%. As long as we maintain our patient census and are able to meet the community needs, then at this point in time, we don't see concerns with being able to maintain the expenses that we incur.
Thank you.
And so that brings us to the estimated revenue generation. And I do want to give a shout out to Kim for helping me with this. I had a couple of calculation errors that she identified, and we cleaned it up. This is what is in the final the final draft of the proposal. And so what we did was we took the 4 months, January, February, March, April. We took the revenue that we have generated in those first 4 months of the year, and that's what the 2025 year-to-date column is. Then we took and did an average revenue per week, and there's approximately 16 weeks in 4 months. And so it's just that first column divided by 16 to get an average for the week. Then our average census over those 4 months is right at 955 clients per week who are being seen. And we divided the average revenue by that amount. Then so now we know that the average amount per client per week is that lower amount that you can see. Total revenues generated by an average client per week, $210, very small. So the next column over, where we estimated the revenue per client per week, we multiplied the per client per week by 1,250. Again, like Misty said, this is an estimate. It's a crystal ball estimate. We know in 11 and a half hour time period, we can push that added number of people through to get services. And so that now we have a new average revenue per week. The next to the last column is simply subtraction. We subtracted our current average revenue per week from the estimated revenue per client per week at 1,250. So it shows that we'll have an increase, an estimated increase in revenue per week of a total of 61,806. Now, if you were to then multiply that amount by the number of weeks that we've made it through this year to date, 16 weeks, you come up with that 4,190,000. And again, the next step down is the total estimated increase year to date with expansion. This is saying if we were already expanded, we had these expanded hours and we were meeting our targets, these 4 months, we estimate that we would have an increased year to date total of 988,892. Okay. And then we just annualized it. You know, there's a third of the year has gone by, so we multiplied it by 3, and then the total estimate income per year is 12,500,000. So I know.
With the column where the total is 210, what is that? Like I see columns, average revenue, estimated revenue, increase in revenue. That column
Right.
just says average amount amount of what? Revenue, expense, what?
Amount of
That's
revenue.
also a revenue column.
All this
Okay.
whole spreadsheet is just
Okay.
revenue.
Okay, I just
And,
wanted
and it's rough. We admit it's rough, but it was a way to estimate potential revenues generated from going from 955 clients per week up to 1,250 clients per week. Any
So-
questions?
More of a comment than a question. I think that's helpful to see what, if we max out at that capacity level, what that increase will be. Of course, it doesn't get that way overnight.
No,
right?
no, we build.
So this group probably already understands that as you grow, you're not going to have that
Revenue.
increase, that revenue right off the bat before you have, and you kind of made that point before as well, Commissioner Kearns, that you will have the expenses kind of front loaded
Right.
as you grow the volumes that will support it. But I think what you've done is you're trying to take the investment from the surplus that you've already made to fund that investment for the growth to cover those expenses until you grow the capacity. Am I saying
Correct.
that-
Yes, exactly. And that will be the recommendation at the end of the presentation. And so, and Misty, you want to come forward and do the timeline?
So the potential timeline is, in theory, if this was all approved today, moving forward, we would begin building position descriptions that were inclusive of the change in times, dates, with the hours, specifically calling out that this is the expanded timeframes. Working and concert with HR for union collaborations. Then that would go through June and July at least, because I know HR has plenty on their plate. Then the next steps beyond that would be the recruitment, hiring, and training of the additional staff. That then takes a couple of months in and of itself, provided all goes well and smooth. Knocking on wood that there would be no hiccups. Adjusting scheduling and operational workflows simultaneously, all of that would have to be built in concert again with the recruitment and hiring. A lot of these things, and I say a lot in a more loose term, but some of these things can be done at the same time. Policies, procedures, and tasks, again, can be done at the same time, can be done as far as what needs to be done differently. From the early morning to the later afternoons, what needs to be done differently from a Saturday shift versus a Tuesday morning. So policy, procedures, and tasks would be updated during this time frame as well. That would be late summer, early fall. Communicating the expanded hours to the community could also be done during the same time period. That could be done, again, to Dr. Thompson's point of the communication into the community with the campaign. We could work that into that campaign project, and ensuring that all of our community partners, stakeholders, anybody that would be accessing services or in need or potentially in need would be able to see this and be able to get the information. And then the implementation of the extended hours could potentially begin as early as this fall. Again, these are approximations, and it would be hindering, no hiccups or major road bumps.
So if I could ask real quick, do you anticipate that the number of staff that we would be hiring this fall would be an adequate number to treat the 1250 per week, or would it be some midway point? Because obviously we hire them, and to the point, you're not going to have them overnight, and so you would probably have this big gap of time before you start generating that additional revenue. And so I'm just curious what that might look like, and if we could maybe parse that out to get a better sense.
So again, this is a new concept for OTPs everywhere. They've always focused on meeting the needs of those who are working and ensuring the hours of the OTP meet their needs. As far as I know, right now, and Misty, I hope you'll correct me if I say something wrong, but right now there are no other OTPs in Spokane County that have extended hours. And because extending the hours is really now starting to focus on a different population, the population that wants to get into treatment but is not yet in treatment. And the original model of how to set up an OTP didn't actually take into account those individuals. It was like, okay, you come to treatment, we're going to get you on the program, you're going to get a job. And that works for some. It doesn't work for all. And so especially all of those people that have shown up at our door and we've had to turn them away.
Well, I guess what I'm asking is if we could get maybe a more clearer forecast, throughout 25, maybe even 26, to show, okay, well, this is the budgeted amounts each month, the estimated revenue each month. We're hiring staff at this month, so we see the increase in cost. We anticipate this many more based on historic data to participate in treatment services each month, so that we can get a better sense of that long-term impact.
Right, and I'm turning to look at our controller, our finance director, to see if that's doable.
And I know some of it would
us
be a
with that
little bit of a guess,
forecasting.
but I think it'd be helpful to me anyway to visualize
Yes.
what that looks like.
Understood. So we could actually just divide the additional, yes, I have a plan in my head. So yes, we can work on that. Oh, while I'm at the mic, I also want to point out that that bullet on policy, procedures, and tasks updates, that does align with our strategic plan goal number 4, which all of our divisions are working on that.
All right. Is there a hand? Oh, go ahead, Commissioner Waldron.
Oh, yes, I was just going to follow up on your comment, Councilmember Cathcart, that there will probably be a time, it'll be interesting how this rolls out if we decide to, move forward with this, because as you're hiring staff, Misty, as you talked about, at some point, you're going to have a critical mass of staff that are either willing to work these new hours, right? Or new staff that come in and get trained. And you'll need to have a critical mass of the right type of staff, right? To really open the doors for those longer hours. So I was just, something visual where you could kind of show along month by month, because it'll be tricky to advertise to the public when you'll be able to make the new hours official as you're hiring people and figuring out if you have coverage, right, across those hours. So I think it'll probably be a moving target, but that's why I think saying October, November seems, reasonable. And then as you get closer to that date, you could have an official date, right? It all depends on the staff that, and the hiring and the training, I would think.
Correct. And you are absolutely correct, Commissioner Waldorf, that having that, as you said, critical mass, because there is a specific grouping of those particular positions that's needed for just day-to-day operations. So yeah, I think getting that as a visual we can put together, because out of that group, we actually were very, very concise on how many and which positions we would need to do that to get up and going. So we can definitely put that together.
Go ahead.
This is probably one of the hardest questions to answer, to know, but do we know there's this many people out there that will seek these services with these extended hours? I mean, I think we can all say there are enough people out that need this service, but are there that many people who will come in seeking this service? Because like you said, not everybody is in the right frame of mind. Not everybody is ready to make that decision to seek this service. Are we confident that we can, essentially double our numbers? Is there that many people in the community that understand they need this service and willing to take that step to show up and get it? And I don't know how you measure that. I'm sure that's a very hard question to answer, but.
So I'll answer part of that, is that Alicia, or Dr. Thompson mentioned earlier that there are no other OTPs in our community that offer expanded hours. And that's a big thing. And there's a large number of individuals in our community that don't have access because it's just not available. The other component to that is that there's a significant trend with Washington State where the nation is on a downward trend as far as overdoses. Washington State is not. Spokane County is at a significantly higher rate than the state as a whole, which gives me pause and gives me significant heartbreak that our community is where it's at and struggling. And it gives me reassurance that in doing this, it is the right thing. And yes, there is that much of a need out there. And moving forward with this would be the right thing because there is that much of a need. And Spokane County's numbers reflect that.
But you're confident those folks that are in need will show up with these expanded hours? Okay.
Yeah.
Yeah, so one of the things I think that, because I asked the same question, one of the things that I think speaks to that a little bit is that they did have to turn away 50-some people in the first quarter. So if you think about that and you expand it out for the year, and then you add the fact that there's increased hours, which should be attractive to other people. I feel like one of the things that the OTP programs, that's one of the key features as opposed to other medical care, is that you kind of want to grab those folks when they're in the right mindset. And so I think having just more of an expanded net to the point that we can afford, because obviously we can't afford 24/7 care forever. But I think if you can open that up a little bit, you will grab more of those people who are in the right moment of their time, because this is not an area like, oh, you want to have your mammogram done, well, our next available is October. Like, all right, that's mammogram month anyway, so that sounds good. So I don't really want to get a mammogram anyway, so that works great. So I think it's a little bit different in the way that the program is, that I think. Obviously, nothing's for sure as well. I think one of the questions that I have that I'm actually a little bit more concerned about is looking at the expectations for Medicaid revenues to be cut. And yes, from our insurers and from the partners that we work at within the state, they are certainly reimbursing and partners with us to address this scourge, but they may not have the ability themselves if Medicaid cuts come into play as expected. So I don't know if you know through your board work, if you guys have talked about that, but that I could see potentially cutting a hole in your very nice,
Right.
presentation.
Right. And actually, that was a point of conversation that Dr. Thompson and I did have. And as of right now, there's not been any indication at the federal level that they are looking at cuts specific to addiction treatment and specifically opioid use disorder treatment. That's at this point in time, but that's at the federal level in those conversations. There's not been any indication in relation to addiction and specifically opioid use disorder treatment.
Because this was identified as a report, my suggestion would be that it be put on as an action item for next month, so the public knows that that's something that the board's going to vote on. Just a suggestion.
And then,
I'm sorry, is that the estimated timeline that we would vote on this next month, potentially? Okay.
and then I do have a question because this is draft. I know that Dr. Blakowski-May had asked us to also include a little bit about the model that we use at our treatment services program, the care model, the harm reduction and that, yes. And so we're happy to do that. Just, if anybody does not want us to do that, please let us know.
Is that just a presentation at our next board meeting?
Yeah,
Okay.
we'll include it. Well, you'll get a final, because this is draft. Now that we know you want us to move forward to a vote, we will make this some changes and updates and make it final and present. Not go through this extensiveness, but
So on that note, is there, I don't know, maybe there's another slide here, but we're not talking necessarily about the opiate money from the city and the county.
we don't know. Again, I have to say, we have not been really involved in those conversations.
Okay.
What we know is that we ended 2024 with an excess of 865,549. And we know that we need some startup costs to cover the cost of those new positions that have to be hired. And that is a pretty skeleton crew. We're hoping that as revenues start pouring in, that we'll be able to expand that team, but we're asking to use some of that excess surplus revenue that was generated by treatment services in 2024 to help fund the expansion.
Okay.
And again, we haven't been involved in the conversations with the city or the county.
All right.
We've just heard of them.
Anything else? Anybody? Go ahead.
So in the years past, the revenue or sort of the surplus of funds that treatment services has traditionally had, with the exception of the 1 year, that's been rolled in to cover sort of expenses in other areas of SRHD's operations. If those go away, because they're going to help fund the expansion, I think there's a reduction in funds that are coming from the state. If there's potential reduction in funds locally that come in, is there a plan on how you cover operations in other areas of the district?
So fortunately, right now, our reserves are quite robust, and they are above what the board has set as their target. And so I believe Kim can talk more about that when she gives her finance update. Okay.
All right. With that, we should probably move on to the next.
Yeah. Okay, thank you.
Okay, I'm just going to be covering April financials. Before I get started, though, I wanted to just give a brief financial update, things that have been happening in the district related to finance. We just this week met with the state auditors and had the accountability audit exit conference. Everyone was invited, but we did have to be careful of a quorum. So I do appreciate the participants of the Budget and Finance Committee that attended. So that was for 2022's accountability report and 2023's accountability report. Those will be published next week through the state auditor's website, but I believe through Ann, we'll be sending the full packet that was presented this week to all board members. So that's forthcoming. Having said that, the auditors are ready to begin the 2024 audits on Monday, June 2nd. So we're prepared for them. This week, we're also wrapping up the 2024 financial statements and the CFA schedule, which is related to the federal and state dollars that we have. That's due tomorrow. And then we also have Department of Health annual BARS report that's wrapping up tomorrow's deadline as well. So a lot of activity. I just want to shout out to all the staff and participants in helping us put that together. It's quite an endeavor. Takes us a good 5 months to get that ready. So that's where we're at with the activities of finance. As far as financials, as Alicia shared with, Dr. Thompson shared with about treatment services, we are reviewing through the month of April. And so in this, this presentation is the agency-wide financial statement. So it looks similar to treatment services presentation, but this is rolled up at the agency, including treatment services. So having 4 months completed of the year, we would expect to be at 33% of budget, and our expenses are at 28.82%. Revenue is at 29.03. So we have just a slight increase to fund balance of $119,997. Part of the reason we're kind of balanced essentially for the month is that we have the Spokane County contribution. You'll see on halfway down, we've received 50%. Halfway, we received the first quarter and then the beginning of the second quarter allocation. So thank you, commissioners, for that. We also have the Foundational Public Health Services funding is at 53.9%. So we have the first half allocation January through June, plus there's some carryover from 24 into 25. So we're a little bit ahead in those revenue streams before the expenses will be spent through June. However, we have not billed for the indirect federal grants or the state, so they're very immaterial at right now at $26,193 and $47.20. So moving down to the next slide, talking about reserves. We have three categories of reserves: the unassigned, which is basically non-dedicated or designated. Committed reserves is the amount that the Board of Health for Public Health Emergencies has set aside, $1.5 million. And then assigned reserves are the management's intention, board's intention, and how we would potentially use some of our reserves for future expenditures, like repairs to the building, capital projects. Additionally, we have the environmental public health, food, and schools and solid waste programs were fee-based, so we monitor to make sure that we're not over collecting on our fees, that we monitor our expenses versus collection. And then we use this balancer to anticipate and put it into the next year's budget so that we're not running a surplus and overcharging. We do expect, unfortunately, in the EPH this year that we'll probably delete those funds and maybe looking at increases this next budget cycle. So overall, our reserves are just shy of $20 million, 19,966,008. So as Dr. Thompson was stating, related to treatment services, the surplus from 2024 of the 865,000 is in the 14,428,605. So to answer Commissioner's question about where the funds went, is they went back into our reserves. So we didn't essentially use it in 24 to balance expenses in 24, but it is part of that population that if we need funds for capital, we would move it from unassigned and then move it into an assigned, or if we had a need to increase the board emergency. So that's where it's sitting today. The flip side also is true. So if any program or project that runs a surplus, it does go into the unassigned fund balance. But the flip side is the same. So if we have a program that uses local dollars and doesn't cover their expenses, then we would have a decrease in that unassigned reserve. So as Dr. Thompson mentioned, historically treatment services has a surplus, but in 23 there was a deficit, and so it pulled from that same unassigned reserve. So that's, but we don't balance, currently we don't balance our budgets with treatment services funding or surplus to offset any of our other program costs. That would certainly be a model to consider. Any questions from anyone? And keep it kind of brief. I know we've got a lot on the agenda.
Okay.
Thank you very much.
Thank you. All right. All right. Get our update from Dr. Velasquez.
So good afternoon, everyone. I'm going to try to keep it brief. I have a whole bunch of short updates for you. If you happen to go to Savannah, Georgia, let me know. The great museum there and 4 great restaurants, unrelated to today's presentation, but I can share those with you. So hopefully this is moving. Yep. So a couple of things I want to close the loop with you on communicable disease and give you an update on where we are on some of those. Pertussis, as you can see, the numbers did continue to go up. And the reason why I bring that up is because if you look at the trend, we had a little bit of a lull when everybody went on vacation. Then we started to see peaks and valleys as everybody came back into school and so on and so forth. And we can say that because if you look at where the exposures occur, it has been consistently in K through 12 and home, which is what you will expect when you have like children that are around other children and then come back home and so on and so forth. So the good news is we still have a significant number of people getting tested, a significant number of people getting post-exposure prophylaxis. So I think our providers are doing a great job of managing to the best of their ability. And if you look in terms of exposure, one of the safest places to be is, of course, in healthcare, because they have very good precautions. Not that I'm advocating to do that, shouldn't go if you do, but if you are, it's actually a very safe place to be. Good news on the respiratory front, as you can tell, we've gone down significantly, pretty much in all areas. And if you look around the country, for COVID, flu, RSV, we have seen a decreasing trend in ER visits, and more importantly, we're seeing the same in wastewater, which tells us it's not there. I see Melissa over there. I'm going to go really fast. So I want to hear your update. So across the country, it waxes and wanes, but going downwards. I do want to call your attention to the fact that the flu season, the Southern Hemisphere, is off to an early start. And it's actually off to a pretty high takeoff. If you look over here, it's about 58% increase compared to the previous year. So we're going to be tracking that. This is from Australia, but we see kind of the same in other parts of the world. Remember that their flu season is the opposite of ours. So we always track to see what's happening there, just so it gives us a little bit of a preview of what we may need to be facing here. So just a heads up on that one. Now, as we move forward, and I have the pleasure of co-authoring with one of our public health nurses and epidemiologists. There's a wonderful article about spring is here, and so it's hand, foot, and mouth disease is one of those things that we don't think about. It's not a reportable condition, but anecdotally, we've had a lot of reports from parents and schools and others. We got a letter, we have a kid, it's all over, and it's a highly communicable disease that can be prevented with good hygiene, but it's really hard with little kids, which is why we get it. So a little bit of a preview on that. This is what it looks like. And this is the typical scenario, less than 5 years old, not feeling really good, all kinds of things happening. The word crabby has been used to describe this, but actually that is not the historical description. That's a misnomer to describe that. But it's actually typically a child that doesn't feel really good. It's got things going on. Some of them can be really sick. Some of them can just be very tired or not feel good, lose appetite, and so on and so forth. I like this picture because it's very telling, and it's particularly very telling on what can you do to prevent it, because you can prevent it. It's a virus, so you can prevent it with good precautionary measures and hygiene. So as a general rule, these are the symptoms that you see in a child or an adult. Remember, adults can get it too. And from what I hear anecdotally, adults tend to feel a little more crappy than children sometimes, which does happen. But the rash is very telling. And these are non-specific symptoms, but when you see the blister type lesions or you see the rash, typically this is a clinical diagnosis that physicians will make. Incubation, about 3 days to a week, give or take. Not uncommon to have infant that just doesn't look good and doesn't want to eat and doesn't have anything else. So be mindful of that. After 2 days or so of the fever, you're going to see the sores, et cetera, et cetera. And one of the things that we worry about is coexisting conditions like herpangina, which is also caused by viruses. Different type of viruses. They're not the same disease. They can travel together, and that's what causes those lesions in the hands and feet and so on and so forth, and can be associated with seizures. So we always tell parents, guardians, make sure that you consult your doctor if symptoms have been there for more than 10 days, there's no improvement, your child is less than 6 months old, is immunosuppressed or has a weakened immune system for any reason, and if they're having trouble in particularly eating or ingesting fluids, because that can cause other issues. So if your child doesn't improve in about 10 days, make sure you're talking to your pediatrician in the event that something else is needed. Now, treatment is symptomatic. There's no treatment for it, but obviously complications can be treated if necessary. So in terms of a public health update, this is where we're at with measles. We got about 1,024. By now, we have 31 jurisdictions. Last time we talked about it was about 24, 25. So it's still moving around, and now we see a greater distribution around the country. And as you know, we've had several cases in King County, knock on wood, none in Spokane yet, although we're ready to intervene if needed. We hope we don't, but we're ready in the event that that happens. Our friends up north now is all over Canada. It used to be one province, and 3 of them now is pretty much everywhere. And more importantly, we're seeing that in North America, Central and South America, and many other parts of the world. The reason why I bring that up, summer is typically a season for travel. Many people go and travel, so make sure that you know where you're going, if there are any health advisories that you need to be aware of, and those can be easily found. These are some of the countries with the highest numbers that we've seen, and beautiful places like Thailand and so on and so forth. So it's just a matter of awareness and making sure you've contacted your provider, what are the appropriate precautions for you and your children. If you do all of that, then you should be able to travel without any major concerns. In terms of community collaborations, we just had our quarterly meeting with the school and child care partners. It's something that every quarter we find the opportunity to provide information and get feedback from them. This was the agenda for that meeting. Our team from Nurse Family Partnership spoke about what they're doing. And as a heads up, in the next Spokane County Medical Society Journal, which is a quarterly journal, we're going to have a write-up on our Nurse Family Partnership to educate physicians and provider PAs and physicians on this particular issue. We had a very long, very nicely done epidemiology update by Veronica. Obviously, we always talk about immunizations, and our friends from environmental public health have a long list of issues. Actually, Veronica and Sandy and I are working on an editorial on bats and bites because, as we get into summer, bugs, bats, bites, they all go hand in hand. So we're going to start reminding people that bats have an important role in the ecosystem, but if they're fuzzy, if they're dead, or they're acting funny, stay away from them because they could have rabies. Now, 2 weeks ago, we did a Facebook Live during the Healthy and Safe Swimming Week celebration. And Sandy Phillips from Environmental Public Health joined me, and we just updated our website. All of the information in terms of pools, et cetera, is brand new or updated, so take a look at that. This week, we had our partners from Inland Northwest Behavioral Health talking a little bit about opportunities for mental health care in Spokane. This is, if you go to our website, Pools and Water Recreation, these folks, remember there's hundreds and hundreds and hundreds of pools in this area, and these folks are responsible for all of them. And not just once, but sometimes multiple times. As we were coming down the elevator, one of our team members of Environmental Public Health was headed to restaurants and golf courses, which we can't forget, they also do all of that. Our friends from FEPR had the opportunity to participate in a national project. Believe it or not, the Smoke Ready partners have been meeting already for quite a while. We typically start early spring before there's any smoke, just to make sure that we do know what we're doing. And we have been engaged in the 2026 FIFA or FIFA World Cup, which will be coming, just to make sure. We couldn't talk about it at the last meeting because it wasn't public information, but now I can tell you. They've been involved for some time already. So we're part of that response in the event that is needed. And we have an event on the 17th to honor our medical reserve corps volunteers that do a great job in the community, providing everything from vaccine clinics to training on Narcan utilization, et cetera. Our immunization folks, we have an event coming up on June the 5th at Center Place in the Valley, which is a short in the arm, a documentary. This is in lieu of our typical Vax Expo, which we're not going to do this year. And there's going to be a simulcast in various locations. So some of us will be there. Thank you to our immunization team for doing that and putting that together. Hopefully we'll see lots of people there. Now, we just launched a collaboration with the city of Spokane. Thank you to the mayor, Maggie Yates, a number of other people, and Josh Pierce from Community Health. Just so you will know, we have deployed some dispensing kits to the public libraries. There is a potential collaboration to have some of this or similar, depending on where it is, in other areas that the public has access to. And we're doing this in collaboration with the city. Our team is providing not only the lineup for all of the Narcan, but training, et cetera, and we have other potential locations. And hot off the press, we're going to be speaking to the YMCA next week to see if we can work with them on something along those lines. So we're trying to make sure Narcan is available. A parent wants to have some, or somebody wants to have some, make it easier for them to get it. Yes, sir.
What would be the process? Do they just go up to the kiosk and they can grab one? Can they grab as many as they want? How does that?
There is a little bit of a control that's why we're putting in places where there's oversight to prevent grab them all and run. So they're going to be dispensed based on, how many the person actually needs, like one or two, not all 8 or 10 at the same time. That's why we need somewhere where there's line of sight. And the folks at the libraries are going to be helping us with that management.
Okay.
Yeah. The goal is to have them available, but not to have them disappear. Because if they disappear, we don't know that they're being used. We don't want them to be sold in the secondary market. So, which you cannot prevent 100%, but good question. So more to come on that. And the point of this is to demystify it and just make it available. Okay. This is this is the last issue, spring issue of the County Medical Society, and Mia Parker had the opportunity to write a continuing medical education piece for those of the many of us that get the journal on childhood firearm injuries, review and prevention. We had done actually a Facebook Live on that right before, and very well received. She actually just finished her master's in public health. So yeah, she's doing a great job. So thank you, Mia. So with that, I'm gonna stop here and see if you have any questions. Wow. And if you're interested, Greater Spokane Incorporated, this is an announcement, this is just sharing. The economic update on June the 11th, one of the components is the state of healthcare, and I'll have the pleasure of moderating that conversation with our healthcare leaders. So we'll learn more about what is it that they're seeing and what is it that they're talking about. Questions?
Anything? All right.
Well, thank you.
Thank you. We've got Melissa here. How long is your? How long do we expect exec session to go? Okay. Do we want to just plan for that for next time? Is that okay? If I just want to make sure that we give you the full respect and time that you need and deserve. So if we can do it next month and pay better attention, that might be a better option. Okay. All the more reason I don't want to cut it short. So, all right. Well, with that, we will then jump to number 7, which is our executive session. And do you want to give just the details of why?
You bet. You bet. So the board will be in executive session for approximately 1 hour based on potential litigation pursuant to RCW 4230-110-1I, and then labor negotiation position strategy pursuant to RCW 4230-144. For the first issue, we'll need board members, Dr. Thompson, HR Danielle Stoddard, and myself.
Okay, with that, we will enter executive session. So. Welcome back. No decisions were made in executive session, and we're back in regular session here. So we'll start with board member check-in. Just go around the room. Patricia, start with you.
Nothing to report.
All right. Commissioner Kearns? Dr. Bukowski-May?
Nope, nothing additional.
Okay. Commissioner Waldron?
Oh, I just wanted to say thank you, Dr. Thompson and your team. I think you're going to come speak to us, the county commissioners, about the health district budget planning on Monday, right?
Yes, ma'am.
Thank you for doing that.
And nothing for myself. Any citizen input? Nobody signed up? Going once, going twice, 3 times? Okay. Well, with that, we are at the end of our meeting. Our next meeting is June 26th, and we will call this meeting adjourned.